بالنسبه لنا ان احنا if we don't know how the inner sphincter works, how to correct defects الموجوده functional colorectal. فهنشوف الابروتش التراديشنال ابروتشز والمودرن ابروتش اللي احنا عملناه وببلش الحمد لله. عشان نعرف المشكله قد ايه complex, the maintenance of continence appears to be complex phenomenon achieved by a combination of anatomic, physiologic factors and relative contribution of each is being unclear. ده احد الريفرنسز بيتحدث على الستيت اوف ذا ارت في فهم الكونتنس. طبعا كلام كله ايه is not decisive. And this is another this is the by Jorgen Wexner, actually it's not a Wexner. Wexner is one of the he's the number one colorectal surgeon in publications. He's the head of the American Society of Colorectal Surgeons now, the president. بيقولوا كده في كان incontinence may be multifactorial. بص بقى الفرق بين الكلام. Due to altered stool consistency, increased rate of delivery of contents to the rectum, abnormal rectal capacity and compliance, decreased inner rectal sensation, and pelvic floor or inner sphincter dysfunction. كلام كتير جدا بس relative contribution بتاعها قد ايه لما عيان يبقى عنده multitude of these factors, how to manage the patient. مسألة ايه؟ مسألة كلها مش clear. This was an editor comment to an article in the Disease of the Colorectal 1999. She said that using traditional research methodology, the reported data had been described as being disseminated research data by some authors and by others as being adding to the confusion experienced in the world of anal incontinence. This was the state of the coloproctology when I started working in this field. So it's a little bit confusing to have a lot of good investigations, but we can't figure out how to use it. On the other side, on the constipation side, some surgeons had claimed that the role of anismus detected on defecation proctography in idiopathic constipation was doubted by some authors due to the high incidence of the condition in normal controls. Anismus is the spasm of the inner sphincter, failure of relaxation of the inner sphincter, or paradoxical contraction of the inner sphincter. So we have a problem. We know we have to be convinced that if we have a spasm of the inner sphincter and failure of relaxation, the patient should have an obstructed defecation. But this is a very respectable group of research. When they say that it's not prevalent with high incidence in normal controls, both ideas should be right. Can we have an explanation on this controversy? Why the research data are like this, and we know that the anismus is important for have a normal defecation, not to have an anismus. We'll see what we could add to this. In addition, very little is known about what symptoms or lithographic findings should be considered as an indication for surgery in patients suffering from large rectal seal and impaired rectal emptying. We see rectal seals frequently on the defecation proctograms, and many of those patients come to us complaining from obstructed defecation. But if we operate upon the data gathered by only defecography and manometry, the success rate of any repair is 40% to have normal defecation. So there is another confusion how to use the anorectal physiology in this. It was a little bit perplexing. So it came the idea. The lack of answers to the questions on how the inner sphincter works is mainly due to the fact that the anorectal segment is functionally highly integrated and should be studied using an integrated approach. No single test can fulfill the job. And if we have the multitude of tests, we have to do some brain work on this. But this is not easy and it's not standardized. So it came on the other side. I do believe personally that if we have a lot of factors working in a special organ, especially if it works in few seconds to start defecation or a fraction of a second to maintain continence, we have to think that there is a physical law which controls these factors. So I went to the other side of the equation and try to figure out what is the physical law which controls or governs all those factors. Is it a law which is already known to us, or we have to construct a special relation between all these factors? And it came the idea that the flow equation had been used successfully by the urologists in hemodynamics and by the vascular surgeons and cardiologists in the hemodynamics. Why not use this in the coloproctology? Because as we know, the cloaca had been separated into the urological system and the colorectal system, and in the females it's the gynecological system. The three components has to work under the same physical law. So if the urodynamics were successful in understanding urology, why not to do some difficult work to try to apply this in the coloproctology? So I didn't invent theory so far. We did some improvement later on, but we tried to use the flow equation to see and to understand how the inner sphincter works. So all what you see till the last few slides are how the coloproctology looks like from the eyes of the flow equation. Okay? Recently it had been published in those publications, and in 2009 had been published in the Periodontology, and now you know the book which I was successfully published and is now available on Amazon.com. It's about the theory, the integrated coloproctology. So we start by definition. Can we have a definition on inner incontinence based on the flow equation? Normally, there is no flow in the inner canal during rest of squeeze. So if we have abnormal flow of gas or bowel contents, normal bowel contents, through the inner canal during rest or during squeeze, whether voluntary or reflex, this is incontinence. So what happens actually in incontinence is abnormal flow through the inner canal in the place where there should be no flow. And in fact, the inner incontinence can be classified into those three states. We mentioned during rest. If the incontinence is during rest, it's a passive incontinence. If it's during trial and voluntary squeeze, it's urge incontinence. The patient feels a desire, but he can't stop the flow. It's urge incontinence. Or during cough or lifting a heavy weight, like what happens in the females in urology, it's a stress incontinence. A lot of authors have neglected this type of stress incontinence, but it's very important to know so as to use our machines and equipment to measure this. Similarly, constipation can be defined according to the flow. Yes, it's a low flow rate through the inner canal per unit time. If he has to go to the toilet normally and evacuates his rectum in 3 minutes or 5 minutes, if there is a low flow state, this is a difficulty. This is a type of constipation. If the unit time is per week, if normally you would have to go 7 times per week or 9 times per week, he goes 1 or 2 times per week. This is also a low flow state per unit time. So constipation can be defined also by the flow. But what controls the flow? Flow came from the theory or from the equation which is used to supply water, gas to our houses or to drain sewage from our houses. So it can be used for liquids. This is originally the original equation, or can be used for gases or solids. And gases behave as a very low flow fluid, and solids behave as a high flow fluid. So the equation applies. So what happens in flow? Flow in general, in yellow as we see, is the pressure interacted by the resistance. In our case, inner incontinence or even during defecation, it's the interrectal pressure and the inner canal resistance. And this explains one of the most strange findings in the manometry, where they failed to have a pressure-pressure correlation between the rectum and the inner canal in normal controls in incontinence and constipation. And there is an overlap between normal and abnormal in the inner canal pressure. 1/3 of the incontinent patients have normal pressure, and 1/3 of normal controls have low pressure. The answer is very simple. It's not the inner canal pressure which controls. It's the inner canal resistance. And this can simply answer the enigma and the question which has been asked by a lot of specialists all over the world. why the inner canal pressure are not successful to give us the answer how the inner sphincter works. And one of the most interesting about this is that they tried to measure resistance in the 60s using machines, probes, balloons, but actually it should be measured mathematically. We'll see what controls the cause. We can measure the interrectal pressure by the manometry, and that's why I insist to have channels in the rectum while measuring, and the resistance can be measured by the difficography. And these are the two major components in understanding interrectal physiology. The interrectal sonography and MRI are important for the anatomy, to have an anatomical functional correlation. It's important to our lab, but the physiology can be understood from the manometry and difficography. We'll see what controls resistance. Resistance of any tube, including the inner canal, dependent upon dynamic viscosity, which is the consistency. We know that evacuation of hard stools is difficult because the resistance is high. When it becomes softer, it can be evacuated easier. The resistance is less. And it's much easier with the fluids, when it's liquid stools, much easier for the gases. And this explains also why the incontinence to gas happens before the incontinence to fluid stools, before the incontinence to solid stools. And you can now actually mathematically measure, if you give laxatives for the constipated patients, the effect on the dynamic viscosity or consistency, and if you give constipating agents for the incontinent patients. It affects the resistance. Okay? But what actually affects in the inner canal is inner canal length and diameter. We know that if you have a good length, we have a good continence. If you have a decreased length, we have incontinence. The diameter is inversely related to the resistance. If we have increased diameter, we know this, we have incontinence. But this is the most important factor, being raised to power 4. The effect is multiplied by 4. 4 times raised to power 4. And the reverse, to have a normal modification, the inner canal has to shorten and open. Okay? This is very simple. So the final look of the equation, this is how we measure the inner canal length and the inner canal diameter simply from the difficography. So we'll find some interesting findings that on the left side we have the inner canal resistance during rest. What happens during squeeze? Actually, in this particular patient, is that the resistance increased 8 times in order to withstand the increase in intra-abdominal pressure, which is by lifting heavy weight, coughing, sneezing, or anything. And in research done by Khalil when he was here, we found that, and this was in the literature, that the contraction of the inner sphincter happens before the contraction of the intercostal muscles during coughing. It's a sequential. And found 2 cases of inner incontinence, the reverse happens. They start contracting the intercostal muscles, and the inner canal does not contract except later on. So they can have stress incontinence due to this loss of sequence. So if you know how the inner sphincter works, you can discover a lot of things, new things. But what happened during defecations? The resistance decreased by 88 times from rest. So we can understand why God had created muscles around the inner sphincter, because there is no organ which can give this versatility of change of resistance except the muscle. It can actively contract and can actively relax it. And there is a change of 702 times between the squeeze and the strain. This is in this particular patient, but it can be much more than this in a really normal individual. So the sphincters are there to maintain length and diameter. The pelvic floor muscles are also here. All the mechanical factors are present to maintain only the length and diameter. They are the final common pathway for all mechanical factors. This is the primary mechanical factors maintaining continence, or what happens during incontinence or constipation. The interrectal pressure is the final common pathway. Remember the slides which have been mentioned about the multifactorial factors or multiple factors maintaining continence and responsible for incontinence. What we eat, what we drink, the digestion, the gastrointestinal motility are responsible for the dynamic viscosity the lower component here. This is the final common pathway about what we eat, what we drink, the rate of intestinal motility, absorption, ends in final common pathway, which is the lung viscosity. The rate of filling of the rectum, the capacity of the rectum, the rate of filling of the rectum, and the capacity of the rectum, and rectal compliance, they have a final common pathway, intra-rectal pressure. And the anal sphincters, pelvic floor muscles, they work through two main factors, retaining diameter and length, full stop. This can explain why when we use the pulse circulage to treatment of anal incontinence, we have obstructed defecation, because it's not dynamic. We have continence, but we lost the change of decreased resistance, which is during defecation. And why when we use artificial anal sphincters, sometimes we have an obstructed defecation also. Okay? Usually to facilitate the measurements, we use the gas as equal to the air, it's the lung viscosity of 1, the water is 38, barium sulfate paste, like the consistency of salts as 68. You can see that the resistance can vary. How much with the change of consistency of the contents? With this equation, we can find that the anal canal pressure is not a primary factor in maintaining continence or achieving defecation, and this explains why the overlap between normal and abnormal. We can find that the anorectal angle doesn't show itself primarily in this equation, as most of the surgeons said, except Professor Shakir and a few other authors believe that it's important, but it didn't prove to be important using the mechanical models for the angles. And actually, we have this debate with some of the Australian and American surgeons that the angles are not important, because you can imagine how many bends in the tubes which brings water to your house or draining sewage from your house, and still you can have a normal flow of water or range of sewage. It's not important, but it has some significance, which I'll tell you about the function and anatomical functional correlation. Perineal descent, we hear that a patient with a perineal descent can have a problem, and we have to correct this perineal descent. Actually, perineal descent is like the hot belly abdomen, or like the Merganian bulge. It's an indication of muscle weakness. And the proof of this is that if you bring 100 patients with perineal descent, 1/3 of them are normal, 1/3 of them are constipated, 1/3 of them are incontinent. So what is the relation between and this equation can explain that it's not important primary factor. But with increased perineal descent, we have more stretch on the pudendal nerve, and this can cause nerve damage in the nerve and neurogenic incontinence later on. That's why you are interested with the treatment of constipation, because it can end up with incontinence. Frequency of anal incontinence. A lot of classifications of anal incontinence about the severity, they use the frequency as indication of sphincter function. Actually, simply I'll give you a simple idea. If you have a patient with stress incontinence, when he coughs, he becomes incontinent. If you give him a treatment for his chest condition, the incontinence frequency improves. This means that it's a good medication for the incontinence. So it's important for the patient, the frequency. I don't say that it's not important, but it's not an indication of the sphincter function. Shouldn't be an indication of sphincter function. It's an indication of how much it disturbs the patient's life. It cannot be used to treat a patient with incontinence, and cannot be used to assess improvement, because if you assess the patient in the winter while he has a lot of coughs and common colds, and you assess him in summer, you'll have another frequency, so you have another severity score. It's not accepted, I think, to understand how the sphincter works. So we'll come to the anatomical function correlation to understand some of other enigmas not known by most of the colorectal surgeons. The external sphincter is like a ring with the internal sphincter, right rings. The internal sphincter is important for the resting pressure, and its damage will result in passive incontinence. And the external sphincter is outside, and is responsible for voluntary control, so it's responsible for the urge and for the stress incontinence. And we have the puborectalis. The puborectalis is not a ring. We know that the internal sphincter and the external sphincter, when they are damaged in part of their circumference, the patient becomes incontinent. But the puborectalis is the main muscle of continence, but it's U-shaped. It's deficient anteriorly. How can you explain this? No one can explain this except when he understands how the inner sphincter works. The explanation is simple. The puborectalis is pushing the inner rectal junction and is attached to the pubis, and it pulls the inner canal upwards and forwards depending on the viscoelastic properties, like the neck of a balloon. When you put a neck of a balloon upwards and forwards, what happens? It lengthens and the diameter decreases. But the internal external sphincter, they work by squeeze action, so if they are lost, they lose their function. But we know that in the high sphincter, I do divide all the external and internal, but if the puborectalis is okay, he is continent. So it's really the main muscle of continence, but no one could explain why it's the main muscle of continence. And it is a very important muscle, which is also neglected, and we'll mention its role. No one could before explain its role, except in our publications, which is the longitudinal muscle area. Few authors in 2003, they said that it's the framework through which all other sphincters work. Are they right or not? We'll try to explain this. But we have to mention that if you are going to pull the inner rectal junction like this, the rectum should be fixed posteriorly properly. If the patient has rectal prolapse, you can find an inner incontinence. And this explains why in 60% of patients with rectal prolapse, they have incontinence. But when you fix the rectum back, 2/3 of them will get incontinence, simply because they regain the function of the puborectalis. And much more important than this, why the puborectalis and external sphincter are part of the few skeletal muscles which have a resting tone. No one could explain this. They say that the anterior horn cells are continuously bombarding those muscles to maintain their tone. The anterior horn cells, do they know what muscle they supply actually? So it's stupid to say that. The actual fact is that we know the operation which is dynamic graciloplasty. Some of the surgeons have used the gracilis, which is a skeletal muscle, and they use a pacemaker. When they put a pacemaker, normally the skeletal muscle have 10% smooth muscle fibers, which maintain tone, but the resting muscle doesn't have to. With the continuous electric stimulation of this sphincter, the percentage of smooth muscle increases to 40% to achieve a resting tone in this muscle. Actually, what happens in the external sphincter of puborectalis, the puborectalis is continuously stimulated. يا رياسة برضه are continuously stimulated by this mechanical stretch. The rectum is pushed backwards and the inner canal is fixed downwards. And we will say what fixes the inner canal downwards. This will keep the puborectalis always carrying the rectum and mechanically stimulated, which maintains its stress tone. So always doing a function. But what happens to, also an important factor before leaving this is that we mentioned the viscoelastic properties of the inner canal. If the neck of the balloon loses its elasticity, if you have a normal puborectalis, still it will not achieve the lengthening, narrowing effect. This explains why after irradiation, some patients develop incontinence. Not only because of the damage of the rectum, which happens also, not only for the damage of the muscles, which happens also, but also to loss of elasticity of the inner canal. This also can explain why patients who have trauma sometimes and have this fibrosis around the inner canal, they cannot be helped by a normally functioning puborectalis. They cannot be stretched upwards and narrowed. All these facts were not known to the world of colorectal surgeons before our theory. And much more important than this wonderful muscle, which is the longitudinal muscle there, you can see something strange about this muscle. Actually, it's distributed like this by a central tendon and branches, which are fixing, traversing the internal sphincter and the external sphincter, and fixed to the inner canal mucosa, peri-inner skin, and one of the slits is running in the ischorectal fossa. Why is this genius configuration? Why? It should be adding a function. You remember when I told you that the puborectalis is pulling the inner canal upwards and forwards? And the inner canal should be fixed downwards. Otherwise, it will flip upwards with the pull of the puborectalis. Some of the incontinent patients will see them have a funnel-shaped inner canal. Actually, they are losing this function because this muscle is fixing the sphincter like the ropes or the anchors of a tent into the skin. So to avoid its upwards pull, but it achieves the fixation while the puborectalis pushed. And this explains why 10% of the patients with inner fissure, when we do a very small sphincterotomy, it's 1 centimeter, 1 centimeter sphincterotomy, or some patients with the fistula, 10%, develop some sort of incontinence after this very small division of the sphincter. Actually, we divide this central tendon in critical parts which we are trying to study to avoid it. And the puborectalis is not functioning properly. If the puborectalis is functioning properly, it will take the function. But if it's not functioning properly, it will be uncovered by this loss of fixation. So it became clear now. We start to know how the inner sphincter works. We start to know why these muscles are there. We start to believe, really, that the longitudinal muscle is a master muscle through which the external and inner sphincter works. Okay? This is the role of different muscles which have been published in our publication, in our book, and in the pelvic perineology, which in open access journal at March 2009, which explains most of the facts which are wrong. We have to move one step forward, which is much more difficult than we had before. We know that mechanical factors are governed by the sensory and reflex factors to maintain continence mainly and also achieve unification. Now, can we integrate these sensory and reflex factors into our flow equation? This was a challenging point and key point to prove that we are right or wrong. How the sensation affects the flow equation? Actually, it's very simple. If you have a delayed sensation, more and more contents accumulate in the rectum before warning the patient, and the intrarectal pressure rises. Simply, it's a pressure effect. But what about reflexes? When we have a reflex relaxation of the inner sphincter, like what happens in the fecal impaction, it's a reflex relaxation. When we cough, it contracts, it increases in length and decreases in diameter. So the reflexes affect mainly the inner canal resistance. So it's now clear. Mechanical factors are 4 primary factors through which all other mechanical factors work. Simply sensation affect the rectal pressure, and reflexes affect the resistance. So in each particular patient, you can measure what happens and how to treat. And with this equation, we could uncover a new type of inner incontinence, which is the reflex inner incontinence. In those particular patients, they have normal sensation and they have normal mechanical factors. But we found that they develop a profound rectal inhibitory reflex when they reach the urge. So the sphincter reflexively relaxes and they can't reach the toilet. We see this in spinal bifida patients, meningocele, some of the post inner surgery, especially in the hemorrhoids. And we could treat those patients, because if you don't know the physiology, you can treat them. We'll see later on what to do. حد عنده سؤال لغاية هنا? If you have any question, it's clear. So it's totally different to have multitude of factors, which we don't know how they interact with each other, but when we have a visual content with the factors maintaining continence and achieving unification, this is totally different. And that's why I mentioned on the back cover of the book that this will draw a line between the speculative analog coloproctology into the digital coloproctology, even high definition coloproctology, where we can have numbers, we can have calculations which can help us to measure this. Okay? The hybrid law in coloproctology, this is very important before going into how to calculate in each patient. Simply, we mentioned the fact that 1/3 of incontinent patients have normal pressure, but still 2/3 have low pressure. Right? لو احنا قلنا تلت العيانين عندهم incontinence عندهم normal pressure، يبقى بالتأكيد ان التلتين ما عندهمش normal pressure. والعكس بالنسبة للكنترول. 2/3 have normal pressure, but 1/3 have low pressure. Still, pressure is there. Can we find the pressure as a secondary factor in such equation? It came simply that if you have an equation, which is well known also in medicine, which have one of the factors in the flow equation which just can do the substitution. What is this equation? It is the law of Laplace. We have been told that the law of Laplace is important if you decide to operate in cell obstruction, because the wall tension increases as the pressure increases and the radius increases. So in the right side of the column, we work at 12 centimeters, we have to operate, otherwise this cecum will perforate. In the transverse column, we use 6 centimeters, because other than this, the wall tension is too high, it will perforate. But they didn't mention that if divided by the thickness, wall thickness, because if you have wall thickness, this will decrease the tension on the wall. So we have now an equation where wall tension equals pressure multiplied by radius divided by the inner canal thickness. So the radius, we have the diameter in the other equation. The diameter is double of the radius, so we can use it. So during defecation, this also happens that the wall tension in the inner canal increases, diameter increases, the pressure increases, and the wall thickness, we'll see what will happen. So we have this final equation, which I call, this is my contribution in this pressure equation, is that the hybrid law of coloproctology. We'll see if it fits into our knowledge or not. Flow, during defecation, we have to increase interrectal pressure, agree? We have to have a low dynamic viscosity. The gases passes easier than the fluids, than the horn stools, than the hard salt. Agree on this? The inner canal pressure has to drop. We know this. All of us working in the barometry, the inner canal has to drop pressure in order to start to initiate defecation, the pressure in the rectum. But here we find that with the flow we have increased wall tension. This is understandable. If you start defecation, the wall tension increases, and we know that fissures can happen at this moment. Okay? But a very interesting finding is that the wall thickness here increases with the flow. This is against what we think, because we believe that during defecation, the anal sphincter thins out. This is what we imagine, all of us, almost all of us. So it was challenging for me. If I can't see the anal sphincter during defecation, now we have the dynamic MRI to see if it increases or not. If it increases during defecation, this means that this equation is right. Okay? We'll see. This is one of the dynamic MRIs. You can see on this side that it's during rest. There is no flow here. This is during defecation. And this is the thickness of the sphincter. It's 1.08 centimeters, and here is 2.31 centimeters. So during defecation. And when I asked Dr. Rani Farouk, our radiologist, doing this, I didn't tell her anything. I told her just measure the inner canal thickness and tell me. She asked me in the phone, what do you expect? I told her to increase. She told me, how did you know? I told her I have an equation which said that it has to increase. This means that we are on the right track. This equation, the flow equation, and the hybrid law are there. What can the hybrid law in coloproctology help us to understand? This can explain very interesting findings, which are how the hemorrhoid, fissure, fistula, and aneurysma develops. How? This is still a theory, and we are working on this to see if it's okay or not. I imagine that in the patients with hemorrhoids, they have the reverse. They may have thinning of the anal sphincter instead of what happens in normal controls, which thickens. So the anal canal tries to defend itself against rupture by increasing the size of the hemorrhoids if they have tendency for the hemorrhoids. So the increase in the size of the hemorrhoids may be starting as a protective mechanism to guard against rupture. Another possibility is that they start straining, and many of them do this before they have this reflex relaxation. They start straining, they don't go to the toilet at urge, and they don't have a relaxed sphincter. They are always busy, they want to defecate before going to the job at their home, and they start straining while the sphincter is still thin without being thickened by the reflex relaxation and the usual relaxation during urge. But what happens during fissure? If the patient doesn't have the protective effect of the hemorrhoids, or this effect of hemorrhoids has been exhausted to its maximum, the anal canal starts to crack by increased tension. If they have the predisposition for the fistula with a wide crypt, they start to have infection, jump into this crypt to start cryptogenic abscess and anal fistula. But what happens if they don't have the tendency for the hemorrhoids, fissure, or fistula? The sphincter starts to protect itself by reflex spasm, like what happens in any physiological system. And this is responsible for the anismus, the spasm which happens in the anal sphincter during diffusion. So, simply, we can understand now better how the anal sphincter works. We can fit the pieces of what had been called disseminated research data into a well-known, well-respected equation, which is the flow equation, and even the hybrid law of coloproctology is a combination of both. Actually, the flow calculator is the measurement where we can use the inner canal length, diameter, and pressure on this. أنا هحاول أشوف إذا كان معايا الفلاشة اللي فيها الكالكليتر ولا لا. هنا في فيروس ولا مفيش فيروس؟ كنتوا عاملين إيه؟ لا ده تلاقيه فيروس. ربنا. أنت شفتني قبل كده وأنا بستخدم الكالكليتر مش كده؟
في الإنترنت.
يعني السايت شغال.
شغال.
اللي هو انتجريتد coloproctology. كل اللي احنا بنعمله بعد كده ان احنا بنديفاين الفلويد اندكس الى الانكونتنس نورمال. لو لقينا الفلو ده كنا بنعمله احنا ايام ما كنا بنقيس بايدينا. دلوقتي خلاص بقت عندنا كالكوليتر هو بيقيس لنا، مش محتاجين نعرف الارقام دي خلاص. وهنا بيبتدي يحصل اول نوع من الانكونتنس وهو السايلنج. يعني عيان ممكن يقول لك انا انكونتنس مش فاهم، بقول له هو كميه كبيره صغيره، يقول لي لا حبه صغيرين. بيفرق كتير قوي عن لما واحد يقول لي لا ده انا كل الستونز بتنزل كميه ضخمه بتنزل. يبقى كل ده معناه ان الريزيستنس او الانتر اكشن بالبريشر ريزيستنس الانكونتنس ابسط لو هو عنده سايلنج بس. قلنا نفرق السايلنج بتاع الانكونتنس من مجرد الستيننج اللي بيحصل في وجود الفايلز او في وجود الفيشر او في وجود الفيسلا. ان العيان لازم اللي بيبقى عنده انكونتنس يبقى معاه انكونتنس توجازس عشان يعدي في الفلو اندكس من مرحله النورمال لغايه ان هو يعمل سايلنج حقيقي. لازم يبقى الاسهل منه يبقى عنده انكونتنس تو ايه؟ جاز. اللي ما عندوش انكونتنس تو جاز بيقول لك انا عندي بيريانال ستيننج، تقول له لا ده عباره عن ستيننج وليس انكونتنس. الصمام كويس، بقول لهم كده الصمام شغال ما دام بيحكم الجازس، انما بيبقى فيه سبب تاني، يا اما بيبقى بروكتايتس، يا اما اكيوت اتاك في هيمورايد، يا اما بيبقى فيشر، يا اما بيبقى فيسفلا. فما كانش هنوصل لهذا الفهم الا لما نفهم الفسيولوجي. يا جماعه الفسيولوجي بيعتبروه اول علوم، لانه زي ما شفنا من الفسيولوجي دخلنا فهمنا الاناتومي اللي ما كانش حد فاهمه. كان كل الناس بتتجاهل اللي قلت لنا وصل. كل الناس بتتجاهل حقيقه البيور التالس اللي هي المين ماسل اوف كونتراست، وانا مش عارف ليه هي ديفيشن انتيريور ومع ذلك المين ماسل اوف كونتراست. مش هعرف غير ما اعرف الفسيولوجي. ثم اجي بعد كده الباثولوجي. لما العين يوصل للكونتراست، لما اجي بقى احسب له اقول له الرينج في مشكله، او الدايمتر في مشكله، او الانترنتال بريشر في مشكله، مش كده؟ يبقى اعرف اوجه علاجي على ايه؟ لو عيان مثلا هديله كونستريتنج ايجنت وهعمل له فيزيوثيرابي على الاسفنكتر، وهديله دواء يهدي الريكتال كونتراكشنز برضه لو عنده ألسر كولايتس. خلاص؟ اقدر من الايكويشن دي اقيس كل واحده فيهم سيبرتلي، ما تضحكش عليا. العمليه بتاعتي اشوف حساسيه الريزيستنس قد ايه اللي انت قدامي. والدواء اللي انا بديه اقدر اشوفها انتريكتال بريشر، والكونسبيتنج ايجنتس اشوفها بالافكت على الديناميك فيسكوسيتي، ممكن تتقاس في حاجه اسمها روتيشنال فيسكومتر، ممكن يبقى موجود في ده الايكويشن اللي احنا بنتكلم عليها. اتس فيري سمبل. يعني انا لما اجي مثلا لعيان عندي مثلا ده بقيس انتريكتال بريشر كام، وبقيس اللينث والدايمتر بتاع الانر كانال اللي خطوه ورا كده. هنقول مثلا انا لما بدخل هنا بلاقي اللي هو انتجريت كولوبروكتولوجي، بدخل على الايكويشن، بدخل بلاقي حاجه اسمها كالكوليتور، بدوس على الكالكوليتور، بدخل على الانكونتنس في كونسبيشن انكونتنس بيشنز. عايزكم تيجوا قريب مني هنا ولا كده. مثلا هنيجي نقول اي ارقام، نضرب اي ارقام. لو قلنا مثلا هنا الكنال لينث، هنقول مثلا ان هو هنحطه على طول، نحط هنا كنال لينث هنا اهي، هنحط مثلا 2 سم، ده اقل من الطبيعي ها. وهنيجي نحط هنا الكنال دايمتر، هنحط مثلا نقول سنتي ونص، سنتي 1.5. خلاص هيديني ريزيستنس. خلاص. وهقول وقت ما هو بيكح، يعني ده مثلا during squeeze reflex squeeze ها، وهو بيكح مثلا هنقول البريشر عنده 60. على طول هيروح ايه كالكوليت دي اندكس، طلع لي على طول يقول لي ايه سوفت فورمد ستول سويلنج. شوف بقت سهله ازاي، مش محتاجين بقى يعني كل البيزك ساينس ده اتسهل انك جاست بتحط لينث ودايمتر، بس هنتعلم ازاي نعملها، ونحط الانتريكتال بريشر. طيب هبتدي بقى، انا عايز اعالج العيان ده، اقول انا عايز بقى ايه، اشوف لو انا عملت له عمليه ورحت ايه من الباك، وهخلي الانر كانال لينث ده 3، واخلي الدايمتر ده مش هوصله للنورمال قوي. لو قلنا مثلا ان انا بحسب في اللاب بتاعي 3 مثلا او 0.7 او 0.8، اقول هعملها 1 مثلا، مش هعمل بيرفكت اوبريشن قوي يعني. خلاص. وبعدين هعمل ريكالكوليشن للريزيستنس، وبعدين اعمل بعد كده اشوف ايه كالكوليت هيحصل له ايه، هيتحول لجاز انكونتنس. فاقدر قبل العمليه اقول للعيان معلش مش هقدر ارجعك نورمال، انا هحسن لك السوفت ستول سايلنج اللي بيضايقك، لكن هيفضل جاز انكونتنس. ممكن بقى نمانج بايه، حاجه تقلل الجاز، تسال الانسبتك نعالجه سيت داون جاز وات ايفر. فنقطه قوه هذا الكالكوليشن ان انا عندي دايمتر، عندي فاكتورز بتعامل عليها واقدر اعمل عمليه. فتره عملت العمليه وبعدين لقيت العيان ما كنتش عامل الكلام ده كله، يقول لي لا بس انا لسه ما اتحكمتش في الغازات. اقول له اهي شايف الاشعه دي احسن من الثانيه يا ماما، ما ينفعش مش كده. الحاجه اللي بعديها كمان، يعني انا اقدر اقيم شغلي. انا كنت عامل حسابي ان انا هعمل 3 و1، فرضا لما جيت اشتغل لقيت انا وصلت ل 2.5 مثلا و 1.2، يبقى اي هاف تو ريدو العمليه. فبتسهل حاجات كتيره جدا. اولا فهم الليترتشر، تاني حاجه ان هي بتخليني كل عيان اقدر اعرف حالته ايه وانهي فاكتور ناقصه، وابلان العلاج بتاعي على هذا الفاكتور، وابريدكت الاوت كم، اقول له يو كان امبروف باي ذس اند ذات، واقدر اقيم اوبجكتيفلي مش سبجكتيفلي نتيجه اللي عملته، واساس مين عمليه احسن من العمليه دي، هل دي فعلا بتجيب ريزلتس ولا لا، ولا انا اي هاف تو امبروف ماي تكنيك او هاف تو ريوبريت اون ذس بارتيكولار بيشنت. يبقى بالتالي قدرت تقدم حاجه بنسميها ديجيتال كولوبروكتولوجي، يعني الكولوبروكتولوجي الرقمي اللي اقدر بعد كده ان انا اعرف امانج العيانين وانا عارف، ونقدر وقتها يجي بقى ايه تامر يجي مثلا يقول لي انا قيست العيان ولقيت اللي انت كده ده محتاج عمليه، يبقى متفقين انا وهو ما نختلفش. مش احنا دلوقتي بنشوف دلوقتي لما حد دخليه على كولوريكتال لاب، المانومتري بيتعمل في العالم كله بطرق مختلفه، لان هو مش عارفين يدوروا على ايه، فبيحاولوا ياخدوا a lot of data. وده على فكره اللي وقعوا فيه اليورولوجيست بعد ما كانوا وصلوا على الطريقه السليمه عملوا اوتوميشن واشتغلوا على فلوميتر، فتاهوا عن البارامترز اللي بتمنتين كونترست وكونسبيشن.
ابتدوا يحسبوا حاجات غريبه جدا. ببساطه الحل في الرجوع الى الفيرجن ايكويشن اللي هي هتساعدني ان انا، وبعدين مساله سهلناها جدا. مش بس سهلناها، ده انا هوريكم بقى حاجات بقى ظريفه جدا هنا. عرفت كالكوليشن سهله بقى، يعني ما عادتش ايه مساله صعبه ان انا اكالكوليت للعيان. هنشوف بس مع العيانين هنشوف مع العيانين بقى مختلفين. يعني مثلا هوريكم مثال. This particular patient لما يجينا نقيس الانتركتال بريشر during rest لقيناه بيبتدي متاخر. نورمالي هو بيبتدي عند 20 30 فيرست سنسيشن، وكونستنت سنسيشن عند 50 60. لقيناه بيبقى متاخر. كان البريشر المفروض في الحته اللي يحس فيها 10 ملم ميركوري اللي هو عند 20 30 عشان ينبهه يمسك نفسه. هو هنا ديليت سنسيشن لغايه 19 لما قبل ما يحس. فاحنا ببساطه لما نيجي نعالجه السفنكتر دي الريزيستنس بتاعتها كويسه. العالم كله يروح جاي على السفنكتر يروح معالجها. انا هنا ببساطه اعمل له سنسوري بايو فيدباك وهرجعه من النقطه دي للنقطه دي. بنعمل له البالون يقعد ينفخها ونقول له حاول تحس وتبرسيف السنسيشن اتلور بريشرز، وبالتالي فعلا يتجاوب. الناس منهم كتير جدا بتحسنوا على السنسوري بايو فيدباك. فبالتالي بدل واحد عرضه للجراحه وهتفشل لان السفنكتر دي مش هي المشكله فيها. المشكله فيها ان هو عنده ديليت سنسيشن بتتعالج بسنسوري بايو فيدباك. فازاي ان انا بختار العيان دي مهمه جدا. يعني دي برضه حاجه مهمه قوي. ده النوع الثاني اللي احنا كنا ذكرناه، النوع الجديد اللي احنا وصفناه بتاع اللي هو ريفلكس انال انكونتنس. خد بالكم في حاجه مهمه قوي. In this particular patient مشكلته مش بس سنسيشن اللي هو اللي احنا كنا ورينا الكيرف الاولاني. شوفوا يحصل ايه مع الانال سفنكتر. نورمال هنا كان السفنكتر كام؟ 52. شايفينها قارينها؟ قارين 52 دي؟ كويس. لما حصل له الوصل للسنسيشن ابتدى يحس، حصل له بص على ايه؟ بص حصل ايه في الدروب في الانر كلام بريشر، شايفه؟ ونازل تحت 20. يبقى دي فولي ريلاكسد سترينج. يبقى حصل له ريفلكس ريلاكسيشن، فبقت مش بس 19 دي 19 دي بعد سفنكتر سليمه ولا تاثر فيها، انما ده حصل له ريفلكس ريلاكسيشن للسفنكتر، فابتدى كانه بيديفيكيت على بريشر 19. خدت بالكم من القصه دي؟ ده حاجه خطيره جدا، محدش قدر في العالم يكوانتيتيت ولا يستخدم السنسيشن والريفلكسز في فهم الانكونتنس. السلايد ده لوحده كافي عشان يوريني العيان ده كانت مشكلته فين. اي واحد عادي هيقول لك انا ايه، ادخل على السفنكتر دي واروح مصلحها. السفنكتر دي عشان كده لما باجي بحسب الريزيستنس بحط نورمال. النورمال عندي حاطه كده عندي في المعمل بتاعي انه هنا كانال لينث ودايمتر حتى 8 مللي. انا مش محتاج اشتغل على السفنكتر، ممنوع، وحاطط الجوريزم كده ما تشتغلش على السفنكتر، دور على سبب تاني. يا سنسوري يا ريفلكس. يبقى بتفرق في الديسيجن ميكنج ولا لا؟ هي دي بقى الرساله المفروض اللي احنا بناخدها. خلاص، هل هتؤثر في الديسيجن ميكنج ولا لا؟ لان ممكن العيان ده اهو يروح على طول عاملين له عمليه يصلحوا فيها السفنكتر. قول لهم سوري العيان ده ما كانش المفروض يصلح السفنكتر. لان ده اللينث والدايمتر والريزيستنس بتاعته كويسه، ما كانش المفروض عشان كده ما ينفعش العمليه. خلاص؟ يبقى تفرق ولا ما تفرقش؟ تفرق كتير جدا. نيجي بقى على حاجات ثانيه. طبعا هنا برضه ازاي بنقيس الستريس انكونتنس؟ بقيس ديورينج كوف. شايفين البريشر بيعلى ازاي ديورينج كوف؟ منهم 90 مش كده؟ لكن بيحصل ريفلكس كونتراكشن ممتاز في السفنكتر. شايفينها؟ شايفين السبايك اللي تحت ده؟ يبقى ده كويس قوي. طبعا دلوقتي بنضيف على الديفكوجرافي كمان ان هو يكح عشان اقدر اقيس اللينث والدايمتر في وقت الكحه، واحس الريزيستنس، واحسب احط الانترالكتال بريشر زي ما احنا شفناه، بحط اللينث والدايمتر في الكالكوليتر، واحط الثانيه واشوف اذا كان عنده انكونتنس ولا لا. مش كده؟ طيب يبقى ستريس برضه انكونتنس. بصوا هنا في الستريس انكونتنس ده شايفين فرقها من السلايد اللي قبليه. بصوا على الكيرف بالاحمر شايفينه؟ قارنوا باللي فوقيه. السفنكتر دي تبقى تشالنجد بالبريشر 90 ده وهي دورينج ريست، فبيحصل انكونتنس. ما قلناش نعتمد على دي قوي لان دلوقتي بنعمل ايه؟ نخليه كح ونشوف بتلاقي في وقت وتقيس بقى دايمتر ولا لا. فرق كبير قوي الواحد يبقى فاهم بيعمل ايه وواحد تاني بيخبط. الكولوبروكتولوجي كان يتخبط في دياجير الظلمات وما زال ولا مخرج الى الان. مش هقول ان احنا this is the only available way. جايز حد يجي بعد كده